Wonderful. Thank you all for joining us today. I'm really happy to see a very diverse group of states and folks. We're really happy that you're joining us all and spending some time with us just before the holidays. We know that this is a very busy and a tricky time of year to get everyone together, so we're really happy that you're taking time out of your busy schedules to join us. We will get started. In the chat below, you can please share some information about yourselves, which state or jurisdiction you're joining us from, your title, and your main injury and violence prevention topic of focus. As a reminder, you are all muted, but we will, you can unmute yourselves at any time by pressing *# so that you can speak up, and we're really happy to have you all here. We will leave the chat at the bottom as we get started with our first couple of slides. Today's topic is how to use data in child and adolescent injury and violence prevention. We're focusing on this topic because we think that it's quite timely for you as you're preparing for your needs assessments and thinking forward to the year ahead. As you're really starting to consider what to focus on and what types of data you have, how you should structure your next 5-year plans, and how you will ultimately share that data. So before we begin, I'll share with you our funding statement. We are funded by the Health Resources and Services Administration, and we serve as HRSA's primary vehicle to address child and adolescent injury and violence prevention. Our technical tips for today: the audio is only being broadcast through the phone lines, so please mute your computer speakers. Our phone lines, if you can hear us, you're already called into your phone line, but you are muted. Again, if you want to unmute yourself during question and answer or to chat at any time, please press *#. We have today's slides are available in the file share pod above the slides. When we move to the next layout, you'll be able to see them. And we do have some links at the top as well. And at any time, you can use the question and answer box in the bottom left corner. This session is being recorded and will be posted to our website within a few days. So I'd like to take a moment to introduce everyone. My name is Maria Catratis. I'm a CSLC Child Safety Learning Collaborative co-manager and a member of the Children's Safety Network, and I'll be facilitating today's discussion. Our first presenter is Bina Ali, who is a research associate at PIRE and the director of the CSN EDARC. She will be our keynote speaker, and Bina will present on how we can use data through the process of identifying and analyzing data for needs assessments, program implementation and monitoring, and outcome measure data. And next we'll have Rachel Heitmann, who is the Injury and Violence Prevention Section Chief at the Tennessee Department of Health. Rachel will share Tennessee's experience with using data, specifically within suicide self-harm prevention. And last but not least, we'll have Alan Dellapenna, who is the Injury and Violence Prevention Branch Head at the North Carolina Department of Health and Human Services. And Alan will share data that are available in North Carolina, how they're monitoring and tracking them, and how they share their data insights to the public. Thank you all to all three presenters for sharing your time and expertise with us today. And without further ado, we will get started with Bina's presentation.
Thank you, Maria.
Thank
Hi,
you,
everyone.
Bina.
Good afternoon. Like Maria said, my name is Bina Ali. I am a research scientist at the Pacific Institute for Research and Evaluation, and I help manage the Children's Safety Network Economics and Data Analysis Research Center. We go by EDARC for short. My background is in injury, violence, and substance use prevention, as well as program evaluation. So I'm very happy to be here today to talk about data use. My team provides data support to CSN and CSN partners, and they use local as well as national data to guide practices and efforts to reduce child and adolescent injuries. And today I'm focusing on using data to improve injury outcomes among children and adolescents. So before I begin, I would like for you all to answer to this poll question. And yep, here's the poll question. So the question is, have you ever used incidents or rates or trends or maps when working on planning a program? So yes, no, or unsure if you're not clear if you have used any data or not. I love seeing 100% yes. Okay, wonderful. This is so exciting. That means you already have background in data and why it's important, but I will do a quick review on that. So there are these are the different types of data that we often use, and I'll focus on the phases of program and when we use them. Okay, so I found this information on one of the CDC's document. I think it's very relevant to us too in injury programs. The CDC identifies important elements that make sure that a program will be successful. The first one that they identify is that we use and adapt evidence-based or evidence-informed practices. So ideally, we want to work with evidence-based practices, but those require rigorous testing and evaluation, which takes time. So what we often do is identify evidence-informed practices that are also relevant to our goals, and we make sure that they have theoretical and methodological sounding approaches, and then we can adopt and use them as applicable to our program. The next element that CDC identifies as important for success of a program is to target risk and protective factors. So we can't oftentimes target the actual injury that we're interested in, like we can't go out and reduce suicide directly, but if we focus on the relevant risk and protective factors of suicide, then we can make that change over time. So we can focus on decreasing depression, which is a risk factor. We can focus on increasing screening for suicide, which is a protective factors, and having identified specific risk and protective factors also helps us ensure that what we're doing through our programs is going to address the important factors that are related to the injury that we want to make changes on. The next element that CDC identifies as important in the success of a program is using strategies that affect multiple levels of social ecological model. Most of us have seen this model before, but it's so powerful. What it's saying is that not just focus on one level, it's not focus on increasing people's knowledge, but make sure that in addition to increasing people's knowledge and their skill set, we're also looking at their relationship with peers, and family dynamics, and also taking into account what's happening in the community and society. What types of policies and practices exist in schools and other settings where youth might be going to. So we could look at all different levels of a social ecological model when we're designing a program. And when a program is comprehensive, then we could be more confident that it has a greater impact, that may have a greater impact once it's implemented to the full scale. So how do we plan a program? When we plan a program, these are the general steps that we think about. This is not a comprehensive step-by-step program planning, but this is like a generalized model that we oftentimes look at. So the first step is assessing the needs. So this includes identifying the problem in the community and determining what the priorities are. The next step is developing program goals, objectives, and activities that are related to the needs that we have identified. As a third step, we would develop an intervention. Here we would focus on identifying evidence-based and evidence-informed practices. And once those are identified, we can then implement them in the community setting. Then we can monitor to see how the program is working. And in the last step, we could see if we could do an evaluation to see if the program was effective and doing what we thought it should be doing once it's fully implemented. So the focus of this webinar is on data use. I will not discuss how we identify and adapt and implement program, although those are important steps of program planning. I will only focus on how we use data at various stages of the program. All right, before I get to that, I want to briefly share why we care about using data. Most of us have this understanding, but I really like just to give a quick overview on the importance of this work. Some of us know that data are important, but don't necessarily see what the applicable use of those are. So I want to talk a little bit about that. We can think of data as information that oftentimes is easier to communicate with partners to and stakeholders who may not have public health background or background on using data to plan and implement an injury program. Data is oftentimes a term that researchers and evaluators use and public health practitioners use. They're simply referring to the evidence behind work. That's really what data is telling us. What's the evidence behind the work that we're doing and making sure that a program is going to be effective and will do what it's supposed to be doing. We often use the phrase evidence-based decision-making. Evidence-based decision-making is like saying data-supported decision-making. We use evidence-based or data-supported decision-making steps to make sure that we bring a high standard of research evidence into our processes and our approaches. I'm sure all of us here agree that evidence is extremely important for researchers, practitioners, and policymakers who are charged with making decisions around what funding to go after and how do we allocate those funding once we receive them and how do we implement prevention strategies. So in other words, data help us make informed decisions. So one of the goals of this webinar is make you all comfortable with the types of data and help you understand when to collect what data, how to collect it, and why. So really, if we can't talk about the rationale behind what we're collecting and analyzing that data, then we can't convince our community partners and participants to share the information and use that information once we provide it back to them. I really like these statements on this slide of talking about the importance of the data. If we don't have data, then we don't know how to plan our program, how to tweak a program, how to know if a program is working or not, and we can't get support for a program without any data. So all those steps are very important. So in injury prevention, we often use data to understand what should be the focus of our program, who are the at-risk populations that need the program. In public health, we often have limited resources, as most of you have experienced, I'm sure. We can't possibly target every single person in our community when we're delivering best practices, so we have to use data to identify who are the at-risk populations or groups. We also use data to understand if a program is working, how it's working, and how to improve it. We can use data to see how our state is doing compared to other states, compared nationally. We can use data in so many different ways to check how our state is performing compared to the national level or compared to the neighboring states or states that have similar social or political climates. So that would be some of the ways we can use data here. Data can help us contribute to existing knowledge in prevention field and inform best practices and policies. So some of you I've seen at conferences, and we're networking and talking about what we're doing in our states and talk about what's working, what's not working, the lessons learned. Oftentimes we disseminate findings of our program, and the hope of all that dissemination and sharing is to make sure that the information we're collecting is going to help increase the it's going to help inform future practices. Okay, so the next poll that I have is asking you about how have you used data? So have you used it for conducting a needs assessment, monitoring a program, and or understanding effectiveness of the program? So I'll give you a few seconds to answer that, and I see some responses coming in. Okay, wonderful. I love seeing these responses coming in. It makes me so excited to see that so many of us are using data regularly. I see that most of us have experience with needs assessment, using data for needs assessment, program monitoring, as well as checking the effectiveness of the programs. And we have all used it to some extent. But there are times when we may not be involved at all phases of the program, so we may be just doing the needs assessment, but not necessarily the evaluation that comes at the end of the program to see if it was effective or not. So these are just the various phases when we heavily rely on data, and I wanted to get a sense of where we're coming from. So we use data before the program to assess the needs. We use data to monitor the program to see how the program is progressing. So this happens throughout the program implementation phase. And we use data to evaluate the program to see how well the program worked. So this comes at the end of the program. So there are different phases of the program, and the three that when we really need data is when we're at the beginning stages to see what to focus on, when we're in the middle stages to focus on how the program is working, and then the last phase to see if the program worked the way we thought it should. So I'll talk about each one of these stages in detail in a few minutes. And just so we're clear, I want to review different types of data that we use. Data could be so overwhelming. There's so many different types and so many different sources. So I want to talk briefly about how do we categorize these data. There is primary and secondary data. Primary data involves data collection from participants. This can include community leaders, key informants, recipients of the program, providers of the program, etc. In order to collect primary data, we do have to interact with individuals. If we're asking them to report on their, let's say, attitudes or behaviors, we have to take some considerations into account. There might be some biases. If we go into school and ask youth about their engagement in violent behaviors, they may not tell us directly because of the social biases, and they may tell us what they think we want to hear. So we may not get the full picture of what's happening. So we can think about how do we ask peers or family members or other community leaders about this problem. The advantage to primary data collection is that we get the answer to the specific questions that we have and that we really want to know about. With secondary data, that involves data that's already available. So for example, data collected by government agencies, like CDC collects the Youth Risk Behavior Surveillance System. It's available to public, it's free. With secondary data, we are limited to what's already available. We don't have a say in how the questions should be asked or when to ask them, how often, and how to ask them. But a huge advantage of secondary data is that it already exists. We could save time by not having to design our own questions or thinking about how do we go out in the community to recruit participants to answer the questions that we have, and we don't have to think about how much money we need or spending too much time with analyzing or summarizing the data when it's already available. So we can just use the existing data to guide our program. It already exists, so sometimes it's also relatively inexpensive. Doesn't mean that one is better than the other. They're both very useful. It's just that there are different types of data to think about, and depending on the needs and depending on the questions we have. If we have secondary data sources already available in our community, it saves so much time and it's inexpensive, but primary data could also help supplement some of the information that we have about our program to make sure that we are targeting the right people and asking the right questions and using the right strategies. So both could be very useful. All right, so data can also be quantitative or qualitative. Data falls under so many different categories. Quantitative data deals with numbers, and the numbers shows us quantitatively what's happening. For example, number of suicide attempts that might be happening in our community. Usually we do statistical analysis to see if there are any statistically significant differences that we observe when we compare our data across some other reference groups. So we can compare our state data with the national data. We can compare our state data with other states' data. We can do statistical comparisons to see if the changes that we see, are they just random and happening by chance, or is there a significant change that's occurring and requires an attention. And we can also do statistical analysis to see changes that are happening over time. Just because we see high rates of suicide in 1 year, it doesn't mean that that's the norm. It might have been something happened in the community that increased the rate this year. Using trend data can help us understand what's happening over time, and if we see a problem is getting worse or if it's getting better, then that's very informative for how we plan our program when we focus on that injury problem. We use qualitative data that includes text and words oftentimes in our program as well. And this type of data comes from interviews, observations, and to analyze this data, we have to review the narrative, and we have to identify themes and patterns of information. So we may not know the number of suicide attempts that are happening, but we may hear from our community leaders or teachers in schools that suicide is a priority issue and they need a program to focus on that in their community. So we can learn qualitatively what are the what's happening and how do we target those, and those could also inform our practices. Data indicators from either primary or secondary data and either from quantitative or qualitative data are useful for identifying areas to focus on and measuring the performance of a program. There's so much data that could be collected, and how we identify the data should, there's so much data that could be collected, so how we identify what data should indicate. So exactly what kind of data to select depends on the goal of the program and what's the theory that supports our program. So if we want to focus on, let's say, reducing suicide rate, then our selected indicators should tell us about suicide-related changes that are happening in our target community. We could use theory too to make sure that we are identifying indicators that would capture what's happening at each level of, let's say, social ecological model. We want to make sure that we're capturing what's happening at the individual level, relationship level, and community and societal level as well. We also want to make sure that what we're measuring is clear, it's accurate, it's important, and it needs to be deemed credible. And oftentimes here, we look at the recommended measures that are provided by leading experts or organizations like Centers for Disease Control and Prevention or the World Health Organization. And we make sure that the information we're collecting and using is going to help improve areas of our program. So data should be clear, need to have a purpose, and we should make sure that they're relevant to our program goals. Again, it comes back down to the program goals. So those are just brief overview on different types of data and thinking about what's available to us and how we use them comes next. So I want to spend some time going over the important stages of a program when we use data. The first step is assessment, which occurs at the beginning of the program. All right, the CDC's definition is that assessment identifies key needs and issues through systematic and comprehensive data collection and analysis. I do want to emphasize on the term systematic and comprehensive. Assessment helps us understand what's needed in a community to address childhood injury and what can be done to address that need. So that's why this step is the #1 step in our program planning phase. So needs assessment is an important step because it helps us understand the gaps. We can identify resources as well as barriers. The information we collect during this phase helps us allocate resources. If we identify that, let's say, rural communities in our state have greater need for motor vehicle safety programs than urban communities in our state, then we can focus on developing or adapting best practices for rural communities who are at high risk. This can become a reference point or starting point. The needs assessment can be used later on in the program as well, but this could be the baseline for our program to see where we're starting from. Needs assessment data can also be used for other programs in addition to the program that it's intended for. When we collect data, we try to disseminate it widely. We share that with our partners, with the community folks, to help them see what we have learned about the community and help them use that information to guide their actions as well. So without assessment, it will be very hard for us to identify and make sure that we are giving attention to the important injury problem. Okay. Right. When we talk about needs assessment, there isn't just one type. We use the word needs assessment broadly, but really we're referring to so many different types of assessments that could be happening, both using quantitative as well as qualitative data. For quantitative data, we could do a survey that captures the need of a community. We can use climate surveys to learn about the environment and the context of the injury problem. We can look at hospital records, police records to find out what the incident rates are. We can also see surveys from previous programs, and we can do hotspot mapping to identify geographical targets for our program. So those are some of the ways quantitative data could be used during the assessment phase. With qualitative data, we can review meeting minutes. So let's say a community gets together in town hall meetings. We can see what discussions they're having and how much time they're spending on certain topics, and if there are priority areas or needs that are being identified through those meetings, we can review those notes and find information about that. We can also interview stakeholders and partners, do a focus groups with them to ask them specific questions that we have about our program and how well, if it's needed or not, and make sure that we're using it appropriately to address the need of the community. You can also look at social media posts, which is one of the interesting ways that we have been using needs assessment data. So let's say, for example, if a school has a Facebook page, we can see what types of messages are being promoted and what the responses are to those messages. If students are responding in the comments and what those comments are saying, do they feel like it's important or not important? Or we can help just see what the school thinks are important issues and sharing widely through social media. We can review local media coverage too. Oftentimes, local news are quick on bringing light to an emerging injury issue. So we saw a lot of news media around e-scooter injuries even before we could identify the available data sources to look at injury scooter data or the limitations and strengths of those data. So local media could be a very useful data source as well. So these are all the different ways we could be looking at it, and this is not a comprehensive list. There might be even some things that I haven't included in here. So looking at your community and identifying different data sources is one of the first steps as well for making sure that we are using all the information available to guide our program when we do assessment. Needs assessment can help us answer some of these questions and should help us identify who the priority population are, what the needs of those priority population are, which subgroups within the priority population have the greatest needs. We may identify that youth have a suicide problem and we want to focus on youth suicide, but when we look at the subgroup level, we may identify that it's the LBGT population that needs a more targeted program. So the subgroup within the priority population we want to focus on is LBGT youth. Needs assessment will help us give that information, and we can make sure that the changes we're focusing on are statistically important or qualitatively important based on the information we learned from stakeholders or meeting minutes and other data sources that we reviewed. We can also see what's currently being done to identify the needs. We don't want to replicate the practices that are already in the community, so making sure that what we're bringing in is something that's needed and something that will add to what the community already has access to or the resources and such. And, excuse me. So needs assessment help us gain knowledge about the priority population, their characteristics, needs, resources, helps us understand the risk and protective factors in the community, helps us determine who needs the program and how great the need is and what can be done to meet those needs. It also informs us about the feasibility of the program. It can help us access and plan the barriers to implementation. If we don't think a program will work, there are certain barriers to it, then we could be more mindful about those things and make sure that we address those issues before we start implementing the program. So all these steps could happen at the needs assessment phase. We can also help us understand if we have the community support, and we want to make sure that the changes that we are trying to implement through our programs, they are realistic. These are the general steps to planning needs assessment. Needs assessment does involve a team. There is so much we can learn from the community to help us develop and implement our program. So we often have to engage multiple partners and form a team. So a team may include injury preventionists who could bring in their implementation expertise, a coordinator who will be working with the community settings to see how the program might be implemented, what the barriers are of those, an epidemiologist, an evaluator to help us think about what are the data sources that are currently available that we may need moving forward, and how are we going to monitor and evaluate the program at the end. So the number of people to include in the team and the type of backgrounds that the team members would have depends on the goal of the program. So for example, if a goal is to develop a social media campaign, then the team might even include someone with communication expertise. The team has to engage stakeholders and partners in the community. If you don't have support from these key members, then it would be very hard to ensure that a program is well received by the community, and it might also affect the sustainability of a program. Needs assessment does require describing the scope of the program. We need to have a clear vision of what we're trying to understand through this effort. It's usually very helpful if you list out specific questions we have. That way we can be clear about what we want to know through needs assessment, and then link those to data that we use to collect and that we use to analyze. We also need to determine the methodology of those data. We talked a little bit about primary data and secondary data. Secondary data could oftentimes be quicker, but it does require identifying data sources. Hospital records are a type of secondary data, but it does oftentimes require working with the hospitals and other entities who are collecting this information. States have different policies around access to data records, especially hospital records, and sometimes it requires creating partnerships that don't already exist, and also requires creating agreements or MOUs. So making sure that those plans are in place and carry it out, and it happens during the needs assessment phase. We can't be doing a program and then not realizing what data sources are available that could be informing a program until it's too late. So all this happens during the needs assessment phase. After determining the scope, listening to questions or listing questions, identifying data sources, we then have to collect and analyze the data. Even the secondary data that are already available, we have to do additional analyses to probe into that data. And data needs to be relevant. Usually we prefer to have both primary and secondary data for needs assessment, but it's not always possible. But having that also helps us make sure that we're getting a comprehensive picture of our community. The findings of the data during the needs assessment can help us inform about what the problems are, what to target on the behavioral and environmental factors, and helps us plan our program more efficiently and effectively. So ideally, we would share the needs assessment data back with the stakeholders as one of the last steps to confirm that the findings make sense, and also to make sure that the data collected for needs assessment actually reflect the community. So even at the needs assessment phase, we are engaging partners and we are forming team, and it is a very thought out approach. Again, going back to the CDC's definition, it is a systematic, comprehensive assessment. Let's talk about monitoring now, which happens during the implementation phase of an injury program. So data monitoring is defined as the ongoing systematic data collection and analysis of our data as the program continues. So this tells us, is the program operating as planned? The purpose of program monitoring is to measure efforts and outputs of the program. So what is being put into the program, what are the activities, and what are we getting out of those activities? And we can also see what's being accomplished. We can look at who is receiving the program. Did the program increase someone's attitude, the self-efficacies? Did it increase institutional policies, etc.? And this information can help us determine what are the preliminary effects of our program. We can see if the program is working the way we thought it would work. Information can help us fine-tune the program elements too. So let me give you an example here. I recently learned about intimate partner violence program that a community is implementing. And the program, after a couple of sessions, the program team learned that morning was not the best time for people to meet for sessions, so they changed the sessions to evenings. And evening sessions increased attendance from participants. More people attending means the more people are gaining from the program, and with more people being benefited, the program can have a larger impact in the community. And monitoring the program led to that identification and addressing of the problem as soon as it was identified. So program monitoring doesn't just happen every month or every 6 months. If the program is, let's say, a 1-year-long program, program monitoring is happening throughout that time frame. After each session, after each resource, we should be looking at our data to see what information we're collecting, not just qualitative or quantitative. We could use both as available, and we can look at data that's both primary and secondary. Here, again, we can think about using different types of data. We could use quantitative and qualitative data for program monitoring. We can collect attendance data. We can look at logs to see if the program is happening the way we thought it should be happening. We could see what's actually happening in workshops and seminars. We can do observations during those workshops and seminars. We can collect satisfactory survey from participants to learn what their perspectives were about the sessions that they attended. Some states are even sharing resources online. So in that case, we can review how many visitors came to that website and downloaded materials. And when we have qualitative data, we can capture information about what the community members think, what their perceptions are, what they think are the strengths and weaknesses of the program. We can interview, we can do focus groups, observations, but oftentimes we also have meeting minutes that we can think about. That's a valuable information that's already available. Oftentimes when people meet, they want to have a systematic way that they could talk about the priority issues, their agenda, and meeting minutes, so we can review those as well. All of this can inform us about what's happening in our program, and again, this is an ongoing process. It's not a one-time data collection effort. It happens throughout the phase of the implementation of our program. If you don't mind, I will get to the questions in a little bit. I'm trying to get through my slides, but I do see some of the questions are coming in. I do see one question about real-life examples. That's really great, and I do want to speak to that towards the end of my presentation, and then also the next presenters will be speaking more about that, but we can certainly go over that if the webinar doesn't address it adequately. There's a question and answer period, so we can discuss that. Okay, so here are the questions that we could be asking during the program monitoring phase. Are activities delivered as intended? How many sessions are being delivered? Who is attending? And who is not attending? That's important information too. Are we reaching the right people? And do the people who we want to be attending, are they present? And are the program, and how many program implementators we're training? So we can see here what is being delivered, how long it's taking, and what's our approach. We can see if the program is working, if it needs to change or tweak the program as necessary. We don't necessarily want to go back to the best practices or change our approaches, but we do want to make sure that we're reaching the people in the right way and making sure that if we need to, let's say, change the time of the program, that we can do that effectively. And let's focus on the program evaluation now. This occurs at the end of a program. All right, so this step helps us determine whether the program met expected objectives and what changes took place because of the program. So here again, we have different types of data that we could be using. Quantitative data can include surveys to see if the recipients reported changes after receiving the program, like did their knowledge change, did their behavior change. We can collect those type of information. We could do hotspot mapping to see if the geographic areas that were identified high risk early on in the program planning during needs assessment, if we're still seeing those areas as high risk, or has that changed because of the program. We can use population surveys and surveillance records. We can use medical records, vital statistics. Those are all quantitative information that are available or that could be collected. So we also have different ways. We can also include qualitative data to learn about how the program worked. We can understand the driving forces and mechanisms that led to the changes. They won't really tell us if the program worked or not, but it could tell us how the program worked. And that's very important information too, because if we're thinking about replicating the same program in different settings or spreading the program after we have done a small test or a pilot study, we could look at the qualitative data to see how it needs to be improved in future programs, or what did we learn from this that we could apply in our future practices. Let's say here's an example. Let's say we saw improvement in suicide screening in a hospital after we worked with medical care providers. Quantitative data may show that the screening rate increased, and the qualitative data might indicate that leadership support also increased, and that led to a policy change about 100% suicide screening, and that was important for increasing suicide rates. So we can use qualitative data to give more context to how the program worked, and also understand what worked and what didn't work, so we can look at elements of various programs through qualitative data. At this level, questions should target at long-term changes. Thinking higher level, what changes are happening because of our program. When looking to see if the program made a difference, we often look at changes in injury risk, hospitalizations, emergency department visits, and deaths that occurred as a result of an injury program. And data to evaluate the program helps us understand if the programs affected the target population that we intended to focus on. Here, I want to give I've given you a quick overview of types of data and when and how to use them at different stages of program. I do understand it's a very quick general overview, but I wanted to just show you there are different ways we can use data throughout the program planning phase and during the implementation. So I want to share an example of how CSN has been using data to inform its practices. And I'll quickly go over this. So CSN has an important role in reducing childhood and adolescent injuries. CSN's mission is to work with states and jurisdictions to allow children and adolescents to foster by addressing fatal and severe injuries in this population. So we help with states and jurisdictions to help build capacity, help them implement effective strategies, and also help them effectively use data to make informed decisions. CDC's work speak to these national performances that measure injury, hospitalizations, safe sleep, and bullying. We want to focus on percent of infants who sleep in safe environments. We focus on rates of hospitalizations for children between the ages of less than 1 and 19 years. We also focus on percent of adolescents who experience or are involved in bullying. When we were planning the program, CSN conducted a rigorous needs assessment. We reviewed Healthy People's Goal. We looked at strategic plans from several states. We also analyzed several surveillance data and surveys. We sought output from experts and stakeholders, including the Maternal and Child Health Bureau. We reviewed all collected data carefully and identified priority areas for us to focus on over the next few years. So I've listed here in the first column some of the data sources that we used for needs assessment. I'll come back to the slide in a second, but I want to share with you that through the needs assessment, we identified and developed our CSN 2023 objectives. We aim to reduce injury, deaths, hospitalizations, and emergency department visits by 4%. We want to focus on 3 priority areas: motor vehicle traffic injuries, poisoning injuries, and suicide and self-harm injuries. The way we identified these 3 injuries is, again, we looked at the needs assessment data and we looked at which injuries to focus on so that we can make the greatest impact. We couldn't possibly focus on every single injury, so we had to think about what are the priority issues. So those are the priority issues that were identified through needs assessment. We also aim to reduce sudden and unexpected infant death and increase safe sleep behaviors, and we aim to reduce bullying victimization as well. So going back to this slide that I showed a second ago, so right now we are in the monitoring phase. We are continuously collecting data to track our progress, making sure that the program is working the way we wanted it to work, identifying any unforeseeable challenges and addressing them quickly, and making sure that the materials and resources that we develop are of importance and are being shared as intended. We look at frequencies and duration of the sessions, including webinars and the TA calls that we have. We look at resources disseminated. CSN has a library of products on their website. So if you go onto our website, you will see resources available for you for free, and it's posted all times. There are fact sheets, infographics, white papers, blogs, and archived webinars. And we can track dissemination of those materials. We can look at how many downloads are happening, how many people are visiting at different times. And we look at attendance records of our meetings as well as our internal meeting minutes and surveys that we collect at the sessions. This is not a comprehensive list of all the data that we're using. This is just a glimpse of the different types of data that we're using across different stages of our program. But this is just to show you that we could be learning so much through different sources at each step of our program. It's not just the rates that we care about, but we also want to see what's happening over time, who's involved, how are the changes happening, who's attending the sessions, are we reaching the right people, and then eventually do evaluation. When we begin the evaluation, we want to look at deaths, hospitalizations, and emergency department visits related to our injury topics. We will also look at national surveys that collect information about bullying and safe sleep practices. Again, those are relevant to our objectives. We also plan to collect qualitative data from stakeholders. And I will, if it's not already in the chat, we'll share some information about the outcome worksheets that we have developed. So when we're measuring deaths and hospitalizations and emergency department visits, we're looking at ICD-10, ICD-10-CM codes. So we have developed those guides that we're sharing widely with people. The worksheets that have those data or have those measures identify specific codes that we have been using to measure child passenger and teen driver injuries, falls injuries, interpersonal violence injuries, and suicide and self-harm injuries as well. So those are just some of the examples of how we're collecting some data, and we're making sure that others have the capacity to assess similar information in their local areas. I already went over this slide. All right, so I mentioned that needs assessment helps us identify the priority topics. This slide shows just the secondary data sources that we'll be using for each one of the focus area that we have identified when we get to the evaluation phase. You can see that there's no one data that we're not just using one data source for each topic, we're using multiple data sources. There's no one data source that's perfect, and there are limitations and strengths to each one of these data sets. For example, YRBS is collected every 2 years. It's not collected from all states, and state participations vary from year to year or every 2 years. So we're taking advantage of different data sets to make sure that we are getting a comprehensive picture of what's happening using the secondary data sources. This is just the secondary data sources. We have a lot of different sources available for primary data collection as well. But I just wanted to give an example of how we need to rely on multiple data that might be available for us to review and use in our monitoring and evaluation. So as I wrap up this portion of the presentation, I want to share that accessing and using data require planning and partnership. Data is as important as the program itself, because without it, we can't tell the story of what was the problem, what happened, and how it happened. We can't talk about how we addressed the issue and what changes led to that. And I hope this overview was helpful. One last thing that I also want to mention is that CSN provides technical assistance for effective use of data to all Title V agencies. And if you have that kind of need, then please let us know. Our team has experience working in different settings and across different populations. And data is not one size fit all, and injury is not one size fit all. So we have to understand the needs of the local communities and help guide the program planning and using data for decision making accordingly. So if you would like to have that kind of support, then please let us know, and hope we can support you in your efforts to reduce childhood injury burden. And I will be wrapping up here. Here's my contact information, as well as the as well as the CSN website. And yeah, I will turn back to Maria to help with the question answer.
Great. Thank you so much, Bina. That was an amazing presentation, and I hope everyone found it very helpful. We did receive a couple of questions in the chat that I'd like you to address. One was from Idea Downey, excuse me. How do you balance community feedback with what the data shows? So how do you reconcile if there's a difference in what the data show versus what the community says?
That's a very good question. Oftentimes when we rely on secondary data, they tell us a lot about our community, but one thing to also keep in mind is how those data were collected, if it was reaching the right population, and also keeping in mind that the data are timely and relevant. It might be data from 5 years ago, and the needs might have changed over time, or the priorities might have changed over time. So the stakeholders or the community members we speak with, they can tell us about what changes are happening or the emerging issues that are coming up. So yeah, I could talk more about that, but also sounds like our other presenters will have some state-level examples that they could share. So we could come back to that. But is that helpful right now? You can unmute.
Yes, you can go ahead and unmute your line by pressing *#, and you can speak with Bina directly.
Oh, hi. That is very helpful. Thank you for answering my question.
Okay, great. Thanks. Thanks for asking.
No problem. How do I mute myself again?
You can press *# again.
Okay, thank you.
I'm also happy to, if others have any examples that they would like to share, we can certainly talk about that too. I would love to hear from states who have had that experience and would love to know how they have addressed it.
Great. Rachel or Alan, if you would like to respond to this as well, please, with any examples, please feel free to respond as well. I have a question for you, Bina. So you mentioned the steps in planning injury prevention programs, which seemed like a linear process. Is this always a linear process?
That's a very good question. Thanks for bringing that up. So when we're planning needs assessment, or collecting data for program monitoring, yeah, the steps that I showed sounded like they're step-by-step approaches, but oftentimes it does require the processes to be iterative. We could learn about something from our community, but we have to go back and replan our program, take it back to the community, make sure that it's clear and it's and it's going to be effective. So it does require a little bit of iteration, but in like if we have to generalize the model, I would say all those steps are important. They somewhat have to happen before the other things could happen. For example, needs assessment have to happen before we could prioritize the problem and before we can implement the program. But in terms of the type of data we're collecting, there might be some back and forth and and that's why it's so important for us to engage stakeholders and working with experts who have that content expertise and who can guide us with our planning. No matter how familiar we are with the community, sometimes we do have to require involving people who are in the community to gain to have their buy-in and making sure that everyone's invested in the program and learning from one another. So thanks for asking that question, Maria.
Thank you for your response. Okay, everyone, so we will move on to Rachel's presentation, but I do want to remind everyone that our question and answer pod, our chat on the left is always open, so if you do think of another question for Bina, you can certainly ask and there just indicate that it's for Bina or Rachel or Alan in particular. So we'll move on, and I would like to introduce Rachel Heitmann from Tennessee Department of Health. Rachel, thanks for joining us.
Thanks for having me, and good afternoon, everybody. In my presentation, I'm going to talk about both quantitative and qualitative data and how we've used data to inform some of our program efforts. So the objectives of my presentation today will be to describe an overview of suicide in Tennessee and describe essence monitoring and the high alert response plan, and discuss the suicide prevention needs assessment survey response data, and describe some of how we've used that data for action. In Tennessee, we have mirrored national trends and have seen our suicide rates continue to increase for the past several years. You can see from this graph that the Tennessee rates have been consistently higher than the national rates. Our rates from 2017 to 2018 did stay fairly stable, but still higher than national rates. We've looked at our data several different ways, including gender, race, and age. And one thing that stood out is the number of suicide deaths at a younger age. In 2018, we had 11 deaths by suicide of children ages 10 to 14. We looked at 5-year trends for deaths of children under age 17 using our child fatality review data and saw those numbers continue to rise. You can see from this graph that we did see a decrease from 2017 to 2018, and I'll tell you a little bit later about some of the ways we've used our data for action to continue that decreasing trend. We also looked at youth ages 15 to 24 so that we could capture the college age population, and also saw that that age group continued to rise. But you can see that between 2017 and 2018, that age group also remained fairly stable. And we did look at method of suicide and didn't see a lot of differences in the percentages of each method of suicide from year to year, but it is really important to always have a trend, and if you can look at a 5-year trend and see if the numbers are staying the same or increasing or decreasing, that can help with your data. So because of this increase in youth suicide, we looked for additional data sources that could identify those at risk before they result in death. We looked at the ESSENCE system, and ESSENCE stands for the Electronic Surveillance System for the Early Notification of Community-Based Epidemics. And this system has historically been used to monitor infectious disease trends and detect potential outbreaks early for things such as flu or hepatitis. The data is collected from emergency departments and is nearly real time, so you can follow the size and spread of any outbreak. And ESSENCE can detect outbreaks earlier than traditional surveillance methods. death data is several months behind. We have final death data about 8 months after the calendar year ends. And then hospital discharge and ED data is also several months behind. Hospitals report into Essence every day, so we can look to see if we see increases in suicide attempt or suicide ideation. And there's a lot of information collected in Essence, including demographic information, such as the county the patient lives in, race, gender, age, and sex. And we look for keywords that are in the chief complaint field, such as self-harm, suicidal ideation, suicide attempt, or suicide. And also look at discharge diagnosis codes. So look at things such as intentional self-harm by sharp object, major depressive disorder, suicide attempt, suicidal ideation, intentional self-harm by poisoning. And our staff go through the list each week of emergency department visits that were reported into Essence and determine what is a suicide attempt. And examples of cases that might get excluded would be if a 2-year-old had been coded as intentional self-harm, or someone that might have come in for something such as appendicitis, but they had come in previously for suicidal ideation. So they would be excluded since their current visit is not for one of the suicide codes. And so in Tennessee, we currently have 95 hospitals reporting into Essence, which is about 80% of our hospitals in Tennessee. So it's not a perfect data source since we are missing some of our bigger hospitals, but it does give us some good information about where we are seeing increases in suicide attempts. And our staff currently monitor trends for suicide attempts, suicidal ideation, and intentional self-harm visits weekly. So we have set parameters within the Essence system, and the picture on this slide shows how we see when there's an alert. So you can see some red dots and yellow dots and blue dots. And then a typical graph that we would get would have the date on the bottom also. So the red dot means it's an alert, and so we have to look at those closer to see where those suicide attempts are occurring. The yellow is a warning, so not quite to the alert level, but higher than normal parameters. And the days with the blue dots mean the emergency department visits were within normal parameters that we've set. And then this is a map that shows where the hospitals are located that report into Essence. So you can see that we have hospitals all throughout the state that are reporting. And this slide shows what our weekly data report looks like. And this is all fake data. You can probably tell by some of the names of the counties and hospitals, but we wanted to show an example of what we are able to see from the data. So as you can see, we get the county, data visit, age, gender, race, chief complaint, and the hospital that's reporting. So that's an example of what the weekly data report looks like that we create out of the Essence data. And so we've been working on an action plan to respond to those areas where we see high alerts. And currently, the Tennessee Suicide Prevention Director is notified of areas where there are alerts so that they can offer more training in those areas. So we also did a needs assessment survey to get qualitative data that we didn't have around gaps and needs in suicide prevention services. So we sent a survey to a broad range of suicide prevention stakeholders and got 281 responses to that survey. And the goals of the survey were to identify gaps in mental health and suicide prevention services and determine what support is needed. And these are some examples of questions that we asked. We wanted to get data on what populations are being served, what services organizations are providing, and the level of involvement with other programs or services. And we also got information about level of interaction with other organizations and agencies to see how well organizations are working together on suicide prevention. And then we also asked what level of interaction best describes how your organization currently interacts within each of the other following organizations. And then this slide shows several additional questions that we asked on the survey to get more qualitative data. We asked how organizations could better collaborate, whether training was adequate, whether agencies have the resources needed, and what opportunities exist for improvement in suicide prevention. And then once we had all the responses back and compiled that data, we looked at the recurring themes within Tennessee. And most of the themes were what we expected as far as we saw themes such as increased access to mental health services was needed, standardized screening for suicide risk, more training in the school system, and supporting families to reduce the impact of adverse childhood experiences, or ACEs. And so I wanted to share just a few of the activities that we have used both this quantitative and qualitative data to improve. Tennessee has increased trainings for those that impact the youth populations. The number of youth impactors trained in 2018 almost doubled from the number trained in 2017. And we are currently analyzing data to determine where training is occurring versus where we see decreases in deaths by suicide. The survey results were also shared with a statewide stakeholder group, and the results, along with the data, will be used to form recommendations for an annual report that will be submitted to the General Assembly. And then we've also been working to increase our dissemination and availability of data to the public. In November 2019, a data dashboard was released that has a section on child suicide along with several other different injury topics. And when you click on the child dashboard, there's a suicide section, and you can sort suicide deaths by sex, race, and overall suicide deaths. And then the dashboard also shows data on the location and method of suicide. So this is a screenshot of the dashboard on this slide, and you can see that there's an infant section and a child section, and so the public can go in and get all kinds of different data on several different injury topics. So those are some ways that we've used some of our data. Does anyone have any questions?
Great, thank you, Rachel. I see Sally Kirshner from Vermont was typing in the chat. Sally, would you like to unmute and ask a question? You can press *# to unmute.
Hi, this is Sally. So in Vermont, we just got the CDC grant to do this work, so it's really helpful to see this. I'm not involved in it as a data person, but this has just been wonderful to see Tennessee's work. I think my question was, is any of this, I don't remember, I don't know what your specific project is for this learning collaborative, and is any of what you talked about relate to what you're doing in this project, in this learning collaborative, or vice versa?
So our goal for this collaborative is to increase the number of youth pactors that have taken the gatekeeper training or the QPR training. So we have been tracking that every month.
Okay.
So both of these things actually relate, because our Essence database that we're monitoring that for youth suicide attempts, and then targeting those areas that have high alerts, and actually targeting those areas for increased training.
So would that, like, hypothesis be in the areas where more youth are taking the training, you see less attempts in your Essence data, or is that too simplistic an association?
That's a good question. We don't know yet, but that's something that we'll be looking at. We've only been monitoring Essence data for less than a year now, So we've just started looking at some of our 6-month trends.
Okay, I get that now, sure. And then on your needs assessment, the survey, that's pretty extensive and impressive. Did you guys do that yourself, or did you contract out for that?
We did that ourselves, and it is a pretty extensive survey. And we're happy to share those questions or that survey with anybody that's interested.
Yeah. Yeah, we may contact you. I'll check with our person who's doing the grant oversight and see, but that's a lot of work. So congratulations. That's pretty impressive.
Thank you.
So yeah. Okay. Thank you.
Hi,
Great,
Rachel.
thank you.
This is Bina. To follow up on Sally's comment, this is so amazing, all this work that you guys are doing. I'm wondering if you could share how long it took for you guys to collect the surveys.
We left it open for a month, the entire
Okay.
month of September, for people to respond.
Wow, and 281 responses. That's amazing.
Yes.
And I'm also wondering, with the responses that you got, because the assessment was across the states, right? So you try to reach all parts of the state to collect respondents and to collect data from respondents. So I want to know if you have done any sort of mapping to see if the respondents who completed the survey, what regions of the state they were representing, and making sure that it's coming from all parts of the states, not just from northern Tennessee or however the regions are divided. I'm wondering if you've done any mapping.
That's a good question.
Of that kind.
Yes, we have, and we're still working on some more mapping, but we did ask in the survey what counties the people that are responding serve.
Mm-hmm.
So we have done some mapping around that.
That's awesome. That's a lot of innovative, exciting work that's happening. And another question that I have, and I'll let someone else ask, I apologize, but this is so exciting. I just wanted to go over a few questions that I was thinking about. So the themes that were identified in the survey, I'm wondering if you took additional steps to rank order and prioritize those needs and identifying which ones should be focused as the primary focus and then focus on others as secondary focus, just because we can't, sometimes what we have to do is we can't target all different parts of the problem, so we have to prioritize our needs, and I'm wondering if that's something that's happening in Tennessee as well.
Yes, and in fact, we're using that needs assessment survey and our data to create an annual report in the next couple months, and that's one of the things that we're looking at is prioritizing those different needs because we saw a lot of needs in that survey.
Right. Thanks for sharing that. I really appreciate it.
Hi, this is Sally in Vermont again. I'm just thinking of we mentioned the Title V grant and performance measures, and Title V is doing their needs assessment now. They have to do one every 5 years. I don't know how you folks are connected with the maternal child health Title V folks in Tennessee, but I would think they would really benefit from the results of your survey as they do their needs assessment.
We're actually working very closely with them. In fact, we're
okay, great.
helping write up some of the action plans for that grant.
Yeah. Okay. Good.
Great. Thank you so much. We have one more question from Idea. Would you like to unmute yourself and ask a question?
Hi. My question revolved around incentives given to get such responses. So in Rhode Island, we're doing surveys as well, and you know, we're wrestling with like what are the incentives to give and how to get people interested in taking a survey. And then also, were you guys, what is it called, like careful about like how long the survey was made in case like it made people shy away from filling it out?
We did cut down the survey a little bit because it was long at first when we piloted it with the group, and we did not give any incentives for filling it out. So our suicide prevention director just called people and emailed people and got people to respond to that.
Great. Thank
Okay,
you so
thank
much.
you.
If you have any other questions for Rachel, please go ahead and put them into the chat, and we'll try to address them right after Alan's presentation. But we want to make sure that we can give Alan sufficient time for his presentation. So without further ado, Alan is going to present on North Carolina's IVP branch. Alan?
Hi, yeah, this is Alan Dellapenna. I'm branch head for the North Carolina Division of Public Health's Injury and Violence Prevention branch. A lot of what I'm going to be presented is part of Scott Preschel-Bell's team's work. Scott's the injury epidemiologist in North Carolina. We're very fortunate to have a very seasoned, experienced epidemiologist. Scott works with lots of people and on lots of different work groups. For us, the data is kind of the foundation of what defines our program and what we work on. But I will acknowledge up front, as I was talking to the team there at CSN and presenting, we're located within the chronic disease and injury section. We're not under the Title V group. We work real closely with maternal child health block grant folks over in the women's and children's health section. But so I just want to acknowledge that. The other thing I want to acknowledge is we are, epidemiology is within our unit. We are an all ages group and all types of injury, intentional and unintentional. So that's kind of the frame of reference for where we're coming from. So I'll start with, as I said, data kind of drives what we do. This is a copy of the cover of our state plan. Our state plan is focused on, our strategic approach is focused on the burden of injury. A page from the plan that, the 5 leading causes of injury are, trying to get this little device to work. Okay, here we go. We cover all ages and the leading causes of injury. Okay, Jenny, this technology is getting me here.
You're doing it great. Now you just need to go down and advance your slide.
I think I have one more in there. Okay, yeah, so these are the topics that we focus on, our priority strategy areas. It's kind of led by the burden of injury in our state. So falls unintentional poisonings, which in this area are drug overdoses or opioid overdoses, violence, suicide, motor vehicle transportation crashes, and we have one cross-cutting one because when you do injury epidemiology, it's by mechanism, but brain injury cuts across so many things in child maltreatment. This is just a screenshot of our branch website. It's as poorly user-friendly as every other governmental website, but on our branch website, this is just kind of an expanded out version of our data and surveillance. So we make our data widely available, and I'll kind of go into some of this later. This is just an example in suicide. Scott and his team put together multiple types of reports, so we make the data available to the public, quick little easy to digest fact sheets. They're usually statewide or topical. We can also break them down by county or other jurisdiction, and I'll get into that later. We're limited by the availability of the data. Some of this stuff is a little older than we wish it would be. We're going through the ICD-9 to 10 conversion like everybody else, and it's causing a little bit of delay in the data. But in general, we try to identify the best available data from out there and put it into reports. So the types of data that's available through our group is, the simple way to show it is through, we call the injury iceberg or pyramid. The top 3 layers we have widely available: death data, hospitalization, and emergency department visit data. The EMS in other ambulatory cases we don't necessarily have available in fact sheet stuff. We have a very close relationship with our EMS agency in the state, but we don't put out standard reports solely based on EMS data. In addition to the morbidity and mortality data sets, we also have we utilize the collection of data reporting systems that I think most states have available. BRFSS, I always mangle that. BRFS is what everybody calls it. We get questions in there every couple years, depending on where we are on different injury Epidemics Champs, YRBS, PRAMS. And then where Rachel talked about Essence, we have Essence available in North Carolina, but we have an additional syndromic surveillance system that's a state system called NC Detect. It works very similar to what Rachel described in Essence. Every 12 hours, the cases that go through the emergency departments, there's 125 or 126 emergency departments in North Carolina. It's loaded into NC Detect, and Scott and the epidemiologists can pull that data down and utilize it for a variety of different injury issues. So a lot of our opioid surveillance work is based on the emergency department. A lot of our surveillance, if it's not death data, it's emergency department data. The hospitalization data in North Carolina is privatized to the Healthcare Association, so there's a little bit more lag, so we use the emergency department. And then we have additional, I call it additional data sources. Probably someone else could define these better. We do a lot of work on the opioid epidemic, so we have a very close relationship with the North Carolina Harm Reduction Coalition. We have one of the largest naloxone distribution programs in the country, and they have a data collection system for overdose reversals that folks can text in. They have a number to call in. We have a syringe exchange program. We have the largest number of syringe exchange programs in the South. Our branch happens to be responsible for that, so that's an example. We do a special data collection system for that. Under our drug overdose work, I think every state now has a prescription drug monitoring program. In our state, it's called the Controlled Substances Reporting System. And you'll see later on in my slides, I have examples of CSRS data. And then we work lots of partners like the Poison Control Center. Safe Kids runs Operation Medicine Drop. And then we do a whole variety of surveys and evaluations that we add in, and we might see some examples of that. So these are questions that Maria asked me to try to touch on. One of them is, how do we monitor and track data? So I mentioned some of this already. We have NC Detect, our syndromic surveillance system. We are one of the first states that had the violent death reporting system. I think it's all 50 states have that now. So that is our data source for homicide and suicide and firearm-related deaths. Under the drug overdose work, the CDC-funded overdose work is within our branch. I know in many states it's not always within the injury branch, but we have a team that does surveillance for overdose. And while the child death review system isn't within our office, we work very closely with child health death review data. And then how do we disseminate data? You've seen some examples already of our dissemination through the website, but I'll summarize it real quickly that we utilize our website with reports, fact sheets, and then anybody can do a data request, and we have lots of customized requests we do. We have lots of listservs that we do for various different partners, multiple newsletters, multiple advisory groups, some legislatively mandated, some just folks that gather together for different advisory groups. And like Rachel showed a dashboard, dashboards have become very popular and utilized pretty widely. I'll give an example of a couple data dashboards. We follow the National Center for Health Statistics, CDC, and CSTE data collection, guidance, and reporting methods. So I think we often get, oh, you should do data this way. We want our data comparable to everybody else's data, so we try to use the definitions that are the conventions that are used across the board. And Scott's pretty active in a lot of the different guidance groups. So I'm going to give some examples here of different ways our data is utilized. This is, we're the source of a lot of the data that's in response to the opioid epidemic. In 2010, overdose became the leading cause of injury, death, overtaking motor vehicle, and suicide, the historic leaders. And it's been the leading cause since 2010, and that little box it bounced into. This is the Department of Health and Human Services for North Carolina's opioid website, and there's a data button on there that our team kind of manages. A lot of what I'm going to say next is, or the next couple things I talk about, we have an opioid action plan in the state. Our team helps manage that and manage the data that goes to it. But if you go to the data site on our department's site, you can get a link to the dashboard, and I'll go to that in a couple minutes here. The data screen that you saw a couple minutes ago from our branch site, this links over to that, and then these little arrows are not in the order that I sent them in, but that arrow sits there nowhere. The bottom one is we not only provide the data, we have some audio tutorials. We also have YouTube videos for utilization. We have a lot of the data sets that are available statewide, but also county level data, and you'll see I break up in the dashboard several other examples. Our epidemiologists work really hard to make the data useful. So a lot of the data feeds can do, like in the overdose arena, you get the standard analysis statewide, but you can also download the data set already done for your county level or health department region or LME MCO region. So that's just an example from where we've put that out there for folks to be able to use. And we were in a phase a couple years ago where it felt like every day we were out presenting, and part of the goal with the tutorials and the YouTubes is get the folks in the county the data in their format and then give them coaching, not just the minutes at the bottom of the PowerPoint slides that are prepackaged, but a tutorial. So this is a couple screenshots I'm going to go through here. We'll see where the animations land. This might be fun for all of us to watch. But this is the summary state. So our opioid action plan is divided up into 7 key strategies that have the highest probability of reducing the burden for overdose deaths. Drug overdose deaths, and we managed collecting the data and the metrics. So you'll see at the top left it says NC, and this, for example, on the main dashboard you can see is how many pills were dispensed. This is the source from our controlled substance reporting system. 445 million pills have been dispensed in a state of about 10 million people. You can see the overdose emergency department visits, the number of deaths, and then, as I said a while ago, we also have reporting in of overdose reversals of naloxone. But the data is also divided by county, so this is a representation of, on the left screen you see North Carolina, all of the 100 counties in the state, you can get your county level data, and the same data is available. So Alamance County had 6 million pills dispensed, 2 overdose reversals, 107 visits. And then this is also packaged in health department regions. I think we have 10 health department regions in this state. So similarly, some health departments are regionalized up, or they manage their response to different things regionalized. Our state has a mental health delivery system. Its acronym is the LME MCO region. So we work really closely with our Division of Mental Health to provide treatment and resources for the opioid epidemic. So this is, all data is also divided into that format. And then for all of the metrics in the dashboard, you can also pull down. This is just one example. So pill dispensing. Since we've started our work a few years ago, the dispensing of opioid pills has dropped by 25%. What this shot shows is that blue graph line is the dispensing rate for statewide. The green up and down is when our opioid action plan started, and then this is an example of the state map, and I had highlighted Brunswick County. So you can get the same data, but on a larger picture view on the dashboard. And for all of our sources of data under the opioid action plan, it is kind of broken down in that area. This is a screenshot. We also have a alcohol. Alcohol is a public health initiative. We're one of the states that's been targeted for privatizing our ABC system in the state. You know, we've seen alcohol sales, places you can buy alcohol increase 400% when states have privatized. So we're trying to get public health data out. Our team, this is a Tableau version of a data dashboard. The previous one was our Shiny as the version. I'm getting the sign. I'll wrap up with the last few slides here. I'll show that another way we describe the data is just the trends since the opioid epidemic started, and as the drugs have changed that have been responsible for overdose, we often try to do a take-home message in the slides. So 6 people die a day, and we're at the point where 80% of the deaths are illicit drugs. this is the Youth Behavior Risk Survey. One of the things that we show is that high school seniors have used opioids recreationally in North Carolina. Almost 20% of them have done that, to try to put the data into a useful manner from a variety of sources. The last couple slides here are on the naloxone side. We try to show folks the interventions that we're doing. So naloxone, this is a real quick summary slide here. It's sort of like an AED defibrillator for heart attacks. It's not going to change the underlying condition. It's just going to save someone's life so they can get care. And our goal in the state is to make naloxone available to anyone. So we have a Naloxone Saves website, and I'll show you drug take back in a moment. So we use a Google map to drive folks to be able to see where they can find a pharmacy in the state that sells naloxone under the standing order. We're big in drug take-back with our partners with Safe Kids. We have a similar Google map that we partner with Safe Kids doing, so you can find a drug take-back location anywhere in the state. Law enforcement carrying naloxone. This is one of many, many maps that we do that shows the number of law enforcement agencies that carry naloxone and the overdose reversals that are done by it. So that was intended to be kind of a high-level overview of just a sampling of how we use the data and some of our sources. So thank you.
Great. Thank you so much, Alan. That was an amazing presentation and I think really timely. I'd love to hear if you have any final questions for Alan. We did launch our evaluation. We are in a constant state of quality improvement at CSN, so we would love to hear how we did today and any suggestions that you may have to help us make these events better. So if you have any final questions for Alan, Rachel, or Bina, please let us know. We are very thankful for your time today. I see a comment from Bina. Thanks for sharing these examples. It's great to see that some states may be collecting so much data from various sources. Having a systematic way to share those data can be very useful. For states where data aren't available easily, those states can think about whom to partner with to access the information needed for decision-making processes. That's a fantastic reminder, Bina. And we would love to hear from you. Our next State Technical Assistance webinar is on February 20th, 2020. It's hard to believe, but we are going to be in all twos very soon. Thank you all for staying on a few extra minutes, and we wish you all a happy, healthy, and safe new year. We'll see you all next year. Thank you all so much.